well correlation, that the clinical features correlates well to the radiological finding, and in few cases, the clinical feature does not correlate. That is the clinical radiological dissociation. And this clinical radiological dissociation usually is seen in few cases in the respiratory medicine. Here, the diagnostic approach and the management will be a matter of concern. Now, I will request all the participant or attendees who are actually now seeing the session to have any query. If they have any query, they can put it into the chat box so that they can be addressed at the end of this session. Now, I will introduce Professor Supriyo Sarkar. He is the eminent personality in the respiratory medicine. Now, he is the HOD in the Department of Respiratory Medicine in College of Medicine and Sagar Datta Hospital. He has vast knowledge and experience in his academic as well as the clinical and the practicing career. Now, I will request Professor Sarkar to start or to speak on this topic.
Thank you, Chairperson, sir. Okay.
Okay, carry on.
Okay. Thank you, Chairperson, sir, for giving me compliments. And also, I am thankful to the ICP API for inviting me to talk on a very interesting subject, the clinical radiological correlation in respiratory medicine. Kaushik? Kaushik?
Okay.
হ্যাঁ স্যার বলুন।
হ্যাঁ, স্ক্রিন শেয়ার করে দাও।
না না আপনি করে দিন, আমি পারমিশন অন করে রেখেছি।
হ্যাঁ, অন করে দেবো। আচ্ছা আচ্ছা।
হ্যাঁ হ্যাঁ
You start.
হ্যাঁ ফুল স্ক্রিন করে দিন স্যার।
Full screen.
Okay, now it is okay. So why this subject is selected? Because I am not a radiologist. I know little about the radiological science, but as a clinician, we often see the X-rays. On the other hand, some patient, particularly in our department, may came with the X-ray only or just radiology only that has been done for some operative checkup or any investigation procedures for operation or for fitness, for giving fitness certificate. And that's why the radiological analysis is very important, and always it is preferable. The investigation is not the answer. The answer is the interpretation of the X-ray on the basis of clinical scenario. Now, this is the first slide. Patient do not have any complaint. A routine checkup shows there are some abnormality and the patient has come to us. What we can see, there is a calcification near the hilum, and if you are careful, then you can see there is a small calcified area in the lung parenchyma also. So giving together, it is the calcified primary complex. We know that at least 38% of population of India has primary complex. This is another X-ray we can show you. The patient, she has a gynecological problem, and for gynecological operations, she had this pre-operative checkup, and that showed that bilateral hilar opacity. Why it is opacity? And the lymph nodes are more or less symmetrical. And why it is hilar? Because there is a gap from the mediastinum. So it is not in the mediastinum, it is in the hilum. And it is symmetrical. So both those two extreme cases, the patient has no respiratory manifestations. One is primary complex, another is sarcoidosis. The differentiation is often difficult, and for all practical purpose, we in primary complex, the evidence of infection will be there. What are the evidences of infection? The MAN2 may be positive or IGRA positive, or now the new test available CYTB that will be positive and that detect the infection. So infection doesn't mean disease. Infection means the entry of the bacilli, and disease means when it manifests. So sometimes of these 38% of us who are infected, about 10% for the lifetime they are activated. But in case of HIV positive person, 10% per year are activated to be diseased. Now, what happens that in 1882, in front of a small gathering, Sir Robert Koch pronounced the discovery of tubercle bacilli, and he got Nobel Prize in 1905. Now, tuberculosis is the disease caused by many bacilli. They are called Mycobacterium tuberculosis complex. Now, what happens? Initially, the bacilli enters taken up by the alveolar macrophage, and they present them to the alveolar macrophage or the dendritic antigen presenting cell, dendritic cells. But the macrophage cannot kill them because of their cell wall. The cell wall is a complex structure, is a tough structure, very difficult to, and there are some chemicals like arabinogalactan that prevents the fusion of the lysosome with the phagosome, and thereby the mycobacterium can survive within them. So what happens? They carry this to the Th2 CD4 cells. And then the CD4 cell activated and they liberates some cytokines, and thereby the macrophage is activated, and this activated macrophage can kill the bacilli, and that is called cell-mediated immunity. There are other cells like epithelial cells and the Langerhans giant cells. Now, if this immunity is not sufficient, then the bacillus spreads throughout the body, and you can see in this patient, he came with the fever persisting with deteriorating cough and also deteriorating health, and patient is very toxic. If you are careful, then you can see some nodular lesions, both lung fields, mainly in the mid and lower zone. Now, it is a misnomer. It is sometimes confused that miliary tuberculosis doesn't start from the apex. It usually starts in the mid zones. And early miliary is very difficult to identify. And the CT shows that there are same. Okay, 1 minute. Sorry, sir, 1 minute. So there are nodules in the lung, and they are almost same size, and they are less than 2 millimeter size. There are some confluent areas. So this is miliary tuberculosis. Now, in this case, nodulars, they are a bit larger and they are of different size, because in the metastatic spread, the occurs in showers. So the size of the nodules will be different. And you can see it takes space. It is positive. The tuberculosis granuloma, when active, may also take space. And that's why differentiation is clinical again. Whether there is a primary lesion and you can see the metastasis also. Now, a lady with nodular opacity. Now, when we interpreted the X-ray, there is one interpretation that is called global view. At a glance, we are seeing the X-ray plates that needs experience. But for the beginners, it is better to have a systemic view. So start from the periphery, from the soft tissue, then bone, then mediastinum, then diaphragm, costophenic, cardiaphenic angle, lung parenchyma বা zones, upper, mid, lower zone, then lastly the hilum, because it is the most difficult part, hilum and mediastinum. Here, if you see the soft tissue, the left breast is absent. Patient has CA breast, and 2 years back that was removed, followed by radiotherapy and chemotherapy. And patient now presents with severe dyspnea, admitted in the RCU. And that dyspnea is relentless and do not respond to treatment. So it is lymphangitic carcinomatosis spread from the breast carcinoma. It also presents with nodular lesions. So different types of nodule present differently. What happens to the primary complex? I am going back to that. The cell-mediated immunity develops, but when cell-mediated immunity fails, there are liver production of these, the epithelial cell, Langhans giant cells, and the origin of those cells is confusing. It is postulated that they comes from the macrophages. Now, what happens when the cell-mediated immunity fails? Then the bacilli are surrounded by the epithelial cell, Langhans giant cells, then lymphocytes, and the fibroblast. And these cells, particularly epithelial cell, is highly metabolically active, and they takes up oxygen, and there is necrosis. As a result, we know that the tubercle bacilli is a strictly aerobic bacilli, and in anaerobic circumstances, they dies. But some of them may keep quiet the dormant in a dormant stage and may be activated later on when the local or systemic immunity is depressed. Now, in this case, what happens? There is caseous necrosis, and this caseous necrosis ruptures into the bronchus. As a result, air enters, and as air enters, the bacilli again multiply. So in cavities, the number of the bacilli is more, and they should be detected. If the sample of sputum is good, then the cavitary lesion, the sputum should be positive. If in a cavitary disease, the sputum is negative, we should think carefully whether it is a case of tuberculosis or not. There are many other causes of cavities. But in some cases, particularly in diabetic patients, the rate of the sputum positivity rate is low. Now, this is a cavity. We can see there is a cavity with surrounding lung lesion of post-primary pulmonary tuberculosis. Now, here patient, the presence with some nodules, and the CT shows that there is a cavity here. And the sputum cavity doesn't mean it is tuberculosis, but sputum is positive. So it is diagnosed as the disseminated tuberculosis. And as the patient has other areas, other organs are also involved. Now, similar X-ray. But what is different here? There are some there are some nodules, they are attached to the pleura, and also there are some interlobular septal thickening. And there is a cavity and a conglomerated lesion. Now, in this case, the diagnosis doesn't depend on the radiological pattern, it depends on the history. When we ask, what is your occupation? he told us that he's walking in a tea stall. If we are satisfied with that history, then we'll be at loss and we cannot make the diagnosis. Now, what earlier you are doing, when we ask this, the patient tell that he went to Haryana in a stone cutting industries. And patient developed this disease and patient is dyspnea, so he came back from him. But that is not sufficient to make the diagnosis of silicosis. Then I asked, what about your co-workers? Then he told us that some of his colleagues in the working place had developed similar disease and two of them died. So that confirms that it is an occupational disease. It is silicosis. Now, what is the cause of cavity? The commonest cause of cavity in silicotic patient is tuberculosis. And tuberculosis usually present in 50% of cases. And so a term is there, silicotuberculosis. Now, Steenberg pattern. What is Steenberg pattern? It looks like small nodules, and it is the centrilobular nodule with some branching pattern. You can say here there are centrilobular nodules and the branching pattern look like the tree in bark. But it is, in our country, it is highly suggestive of tuberculosis, but it doesn't confirm the diagnosis of tuberculosis. Again, the sputum is the answer. Sputum for CBNAT. Now, this patient, X-ray looked as a very difficult one. You can say there is a left-sided pleural effusion, but aspiration was negative. Nel cannot aspirate fluid from that. At that time, USG was not available, but the diagnosis is very easy. Now, this girl had amputation of the left leg. When asked why this leg is amputated, she told us that 10 years back, she had an accident, street accident, and that's why her leg is amputated. But we should not satisfied with that. Now, at the age of 10, her leg was amputated. Do we expect that her family member will tell her that she had a malignancy, that's why her leg is amputated? So it is a sarcoma, osteosarcoma of the leg, that's why the leg is probably amputated, and all these things are the metastasis involving both lungs. Now, the apex is shifted to the left. What are the causes of shifting of the apex to the left? It may be in the heart, cardiomegaly. It may be in the lung, that is the collapse or fibrosis of the left lung, or effusion, pneumothorax of the right lung. But what are the causes of left-sided shifting of the apical impulse when heart and lungs are normal? This is the question, my favorite question. And one of the important cause is you can see the sternum. And that's why it is, and that's why heart is shifted to the left. Now, I was then at North Bengal Medical College. An old man from the remote area of Nepal came with severe chest pain, cough, little expectoration. And why there is severe chest pain? And that is pleuritic chest pain. he actually came with placing his right hand in the left side of the chest to splinting the area. And she is a very toxic, prostrated, and on examination in the back, there was dullness, bronchial bass sound, some crepitation. So the diagnosis was pneumonia. And the classical pneumonia or typical pneumonia, nowadays, because of the antibiotic therapy, the typical picture of the pneumonia is often not founded. So in this case, X-ray, what X-ray shows, there is a areas of opacity, and respiratory diseases can be divided into three if it is unilateral. Mediastinum remains central, that indicates consolidation. Mediastinum shifted to the same side, collapse fibrosis. Mediastinum shifted to the opposite side, that is pleural effusion, pleural disease. The main important point of the consolidation diagnosis is that mediastinum should be in the central position. For unilateral disease, in all bilateral disease, mediastinum would be central. Here you can see the left border of the heart is clearly visible, as well as the diaphragm is clearly visible. So the position of the consolidation is below the oblique fissure. That means it is in the lower lobe and the apical segment of the lower lobe, as the diaphragm is clearly visible. And if you can see, there is a air bronchogram, and air bronchogram is the classical sign of consolidation. Now this man went to his office, and he was okay. At that time, he suddenly had a bout of cough. Then he fails, and there was a shock. BP was not recordable, and they carry him to the nearest hospital, and where he was resuscitated with fluid and also steroids. After that, he has a X-ray, and that X-ray shows a thin wall cyst in the right cardiophonic angle. You can see the right cardiophonic angle, there is a cyst. And as there is abnormal X-ray, they send it to chest OPD. Next day, he come to our OPD, and we search, ask for the old X-ray. And his X-ray, old X-ray, was like looking like that. It is a filled up cyst, and now it is empty cyst. So it is a rupture hydrated cyst that caused anaphylactic shock in this patient. Fortunately, patient has resuscitated well. Now, after a hernia operation, this man was in leukomite reaction, and his WBC count was about more than 25,000, with some polymorphonuclear leukocytes, as well as some immature cells are also there. So there are X-ray shows there are multiple lung abscesses. Now the next question that should come, if it is a hematogenous spread of infection, why it is on the right side and left side is spared? So we again search for the old X-ray, and that showed there are multiple bulla on the right side. So it is an infection over a bulla. Now you may ask the question, the emphysema is a bilateral disease. Why bulla are only on the right side? We dig it out. But now I should proceed here. But in case of always search for the old X-ray, that will give a clue to your diagnosis. Now this patient, his name was Northoram. At the age of 18, he went to a red light area near Patna and developed urethral stricture. So he needs monthly the urethral dilatations. Now he developed some respiratory problems, and as a result, he came to our OPD and referred from the urology department. And we see a air fluid level. So what are the causes of air fluid level? Hydropneumothorax maybe, then it may be the lung abscess, or sometimes consolidation of the middle lobe that is bounded above by the transverse fissure may looks like a horizontal fluid level. So here, how we can, the clinical examination is very important, and also the duration of that. And in clinical examination, in the lung abscess, there will be expectoration, mucopurulent expectoration. That is the important. And in the hydropneumothorax, there will be little expectoration. If not, there is a communication, the bronchopleural fistula. So lateral view is very important to differentiate. Nowadays, CT is available and it is not a problem, but at those time the lateral X-ray was very important, and here you can see that it is bounded by the transverse fissure. So we treat him with the antibiotics, and after that it is the oblique fissure. You can see here it is the oblique fissure line. This is the oblique fissure line, and that is below the fissure line. So it is again the superior segment of the lower lobe. And patient was treated for lung abscess, and ultimately patient went to urethral reconstruction surgery. Now this patient, again, there is a horizontal fluid level in the left side. So it is hydropneumothorax. But where is the collapsed lung margin? There is no collapsed lung margin visible here. So it is the number 3 X-ray. Number 2 X-ray shows there is a pleural effusion. You can see the upper border of the pleural effusion. It is concave upwards and medial. This is the classical pleural effusion. After aspiration, air enters, and that's why there is a horizontal fluid level of hydropneumothorax. And again, then again the air absorbed, and it is again the pleural effusion. But here you can see that the upper border of the is convex. That means there is some encystment of the pleural effusion. Now, if you are careful, here you can see there is a deformity of the spine, and that is visible here. There is a gross deformity of the spine, and the gap between, there is a destruction, practically there is a destruction of the vertebra. So whole etiology is tubercular origin. Now this lady had hemoptysis, and after hemoptysis, X-ray was taken, and that X-ray showed that heart is shifted to the left. Normal position of the heart is 1/3 to the right, 2/3 to the left. But here, the whole heart is shifted to the left. So there is something abnormal. And if you are careful, then you can see there is a triangular opacity behind the heart. So it is left lower lobe collapse. Left lower lobe collapse looks like that. At that time, CT bronchoscopy was not available, and we do physiotherapy. And with that, the clot comes out and patient lung expanded. Now, this is the left whole lung collapse. That is, the whole lung is opaque and the mediastinum is shifted to the left side. But if you are careful, then you can see there is a sudden cut-up of the left bronchus. And so bronchoscopy will reveal the diagnosis. And you can see there is a lucent area with a margin. That is that the right lung herniate up to this level. So in case of collapse, what happens? That at the beginning there was dyspnea, but as opposite lung takes up and there is accommodation, so dyspnea gradually decreases, and dyspnea is not a presenting picture of collapse. Even the whole left lung is collapsed. And this is right whole lung collapse. And if you are careful, then you can see there is a metastasis in the left lung also. So if you see the collapse, and the diagnosis of the collapse depends on the clinical sign, there is a dullness, less movement, breath sound. The classical sign is breath sound absent and mediastinum shifted to the same side. But in case of fibrosis, the capitation is the main finding for capitation. Without getting capitation, you cannot diagnose lung parenchyma fibrosis. And if capitation is absent, we should search for the post-tussive capitation. Ask the patient to cough, and after that, you hear post-tussive capitation. There are three things. A post-tussive examination should be done. One is post-tussive capitation. One is post-tussive suction. It is often found in cavities. Another is to differentiate between capitation and rub. You have to ask the patient for coughing. That will change the character of the biphasic capitation. Again, there is a collapse of the left lung. So we should search for more than that. And here you can see patient is intubated in ICU, patient is intubated, and this is the common thing we are noticed, that as the right bronchus is the continuation of the trachea, it sometimes enters the right bronchus, or sometimes the tube may migrate later because of the inadequate fixing of the tube, and you can see the tube is on the right side, and that causes collapse. Actually, patient was admitted in an ICU, and they thought it may be a effusion, but the differentiation of effusion and the collapse is, in case of collapse, the mediastinum will be shifted to the same side. In case of effusion, mediastinum will be shifted to the opposite side. In both cases, breath sound may be absent or diminished. Now, this is another case. You can see the oblique fissure here shifted upwards. So there is a volume loss on the left upper zone. And there is a mass here in the left high lung. And that looks like an S. Upper part is due to collapsed lung and lower part due to mass. And if you are careful, then you can see there are also the ribs are eroded. So it is a case of bronchogenic carcinoma. The only thing we have to go for is to prove it by bronchoscopy and other investigations. Now, this patient had presented with dyspnea, hypoxia, and also there are bilateral lung infiltrate. So we diagnosed the case as ERDS and managed it accordingly. But if you are careful, then you can see that the shape of the diaphragm. Here, the highest point is shifted laterally. So there is a effusion on the right side, subpulmonary effusion, that causes shifting of the highest point of the diaphragmatic dome laterally. So ultimately, it was found that it is not ARDS, it is cardiogenic pulmonary edema. So differential joke, the cardiac slot is normal. The diagnosis was cardiogenic pulmonary edema. And cardiogenic and non-cardiogenic pulmonary edema, the difference is that in cardiogenic pulmonary edema, it is rapidly reversible. But in case of ARDS, the mortality is very high, and the management is prolonged. On the other hand, when there is some pathology in the diaphragm or in the abdomen, the diaphragm is also raised. And in that case, the peak is in the midline. And that there is a cyst in the liver, and you can see the daughter cyst also. And the one thing that is absent or peculiar is that the abdominal hydatid or liver hydatid, they are often calcified, but here calcification is absent. But it is mainly I am demonstrating that in case of liver mass or causes in the abdomen, diaphragm may be shifted upwards, but in that case, the peak of the diaphragm, dome of the diaphragm would be in the midpoint. But in case of subpulmonary effusion, the peak will be shifted laterally. Now, this is, you all know that this is Chilaiditi syndrome, and you can see the hostation of the colon. The colon comes between liver and the diaphragm. But the importance of this Chilaiditi syndrome is that to differentiate between peptic perforation, emergency conditions, peptic perforation. In peptic perforation, it is a free air below the diaphragm. Here, it is not free air below the diaphragm. Now, coming to the left dome of the diaphragm, here, left dome of the diaphragm is raised. The commonest cause of rise of the left dome of the diaphragm is eventation. Eventation means weakness of the diaphragmatic muscle. That's why due to negative pressure, diaphragm is pulled upwards. But here you can see there is a mass in the left hilum that indicates it is probably the phenix palsy. And how we can diagnose phenix palsy, unilateral phenix palsy, by sniff test. Under fluoroscopy, you can see that when the opposite dome shifted during inspiration downwards, but during inspiration, the diseased dome will shift the opposite side, the upwards. So this, comparing the movement of the left and right dome, you can see whether there is a unilateral diaphragmatic pulse. In case of bilateral diaphragmatic pulse, it is very difficult, and in those cases, you have to see the manometry by esophageal pressure and the stomach pressure measurement. And also the clinical sign is particularly important. Paradoxical movement of the abdomen is important. Now here again, the left dome is raised. And you can see that it is the stomach that is dilated. What are the causes of dilated of stomach? It may be pyloric obstruction, it may be gastroparesis, erophagia, particularly NIV patients. But here, if you are careful, you can see the patient is intubated. And it is very rare X-ray and esophageal intubation. And after esophageal intubation, patient was ventilated. So yeah, the air comes directly to the stomach. Stomach is dilated, and that's why it looks like that. It is esophageal intubation. It should be immediately identified, and withdrawal of the tube should be done, and putting the tube in the trachea should be done immediately. Otherwise, patient will deteriorate. Now there are bilateral paracardiac opacities. And there are some nodular also. You can see there are some nodular opacities. What is this? This is the hypertrophic transverse process of the vertebra. Why this is hypertrophic transverse process? It is the extramedullary erythropoiesis in case of thalassemia patients. So chest X-ray, without knowing, you know that the skull X-ray should be done. Chest X-ray can be a mirror of the systemic disease again. Bulging of the pulmonary bay. Here means there is a possibility of pulmonary hypertension. Now, classical picture of the pulmonary hypertension is that the central vessels, pulmonary vessels, are dilated. That is noticed by the fullness of the pulmonary bay, but there is peripheral pruning of the vessels, and that is the cause of the pulmonary hypertension. So what is the cause of pulmonary hypertension here? If you are careful, then you can see double contour of the right border. And this is due to dilatation of the left atrium. So it may be a mitral heart disease. So what is mitral stenosis doesn't cause the enlargement of the heart. So it is either mitral regurgitation or a combination of mitral stenosis, mitral regurgitation. On the other hand, you can see the fullness of the pulmonary bay, the pulmonary vessels. Compare the pulmonary vessels of these two X-ray. Here there is pruning of the vessel. Here you can see the pulmonary vessels, they are dilated. And that is due to flow. In the ASD and VSD, those are the only causes of pulmonary hypertension in which the blood is recirculated. As a result of that, the pulmonary vessels are dilated. But why this patient come to our OPD? Because VSD patients are detected in the childhood, but ASD patients are often present to the respiratory physicians with a recurrent respiratory tract infection. This 18-year boy has a recurrent respiratory tract infection. He came to our OPD and they are giving antibiotics, bronchodilators, etc. And patient was happy with that. One day, one person noticed that this mark and whole scenario was changed. So it is dextrocardia. And when that is noticed, everybody jumped into the case. A normal case become very highly academic case. The liver dullness on the left side, top space on the left side, and somebody discovered that there are some bronchiectatic changes, there was sinusitis, so the diagnosis was Cartagena syndrome. Now, how to prove that the dextrocardia is there? It may be shifting of the heart. So ECG was done, and ECG, you can say the right chest lead are positive and left chest lead are negative. The V6 of the right side is positive and V6 of the left side is negative. And that's confirmed the diagnosis of dextrocardia. This lady with severe respiratory distress come to our OPD, and there was a tumor on the right side. You can see there is a tumor on the right side, and if you are careful, then you can see there is heart is enlarged. There is cardiomegaly. Patient presented with respiratory distress, and there was cardiomegaly. There was a tumor like mass on the right side near to the horizontal fissure. What we did, we gave her the diuretics, and after that, the tumor disappears. And her size also reduces to some extent. And so it is called phantom tumor. It disappears with diuretic therapy. This is phantom tumor. It is very rare nowadays. We are not getting this type of X-ray. This patient presented with excruciating chest pain going downwards, above downwards in the back towards the abdomen, and X-ray showed there is a left-sided pleural effusion, there is no doubt, and there are some opacities like this we cannot explain. And the CT angio, so it is a dissecting aneurysm. So the history is very important in diagnosing the. Is there is any problem? Everybody can say
Yeah, no problem.
no
I
problem.
think
Very
no
good.
problem. There is no problem.
Okay. So there is a dissection of the descending aorta, and that causes there is leaking, there is a causing left-sided pleural effusion. Sometimes meticular clinical examination has no substitute. So this X-ray apparently looks like normal. The clinical examination shows that in the right infraclavicular area, there is a monophonic rhonchi, localized monophonic rhonchi. And if you carefully see the X-ray, there is some lucency on the right upper zone. And X-ray also shows that there is the lucency here. And bronchoscopy, we can, in the right upper lobe, we detect a small growth. Now, what happens when there is a small growth partially obliterating a bronchus that will cause acts as a ball valve, and as a result, air enters but cannot comes out. When the whole bronchus is obliterated, then that will cause collapse. So this is the early part of the collapse. So where there is a hyperlucency of a area of the lung, that is partial obstruction of the bronchus, and that is due to malveillance. Now, a middle-aged lady with established diagnosis of SLE. And it is the diagnosis of SLE was done. She was treated with, as usual, in the medicine department, and suddenly she presents with acute deterioration, severe dyspnea, fever, hypoxemia, and hemoptysis. Hemoptysis may be absent in 50% of the cases. And the clue is drop of hemoglobin and rise of DLCO. And so the chest opacities are diffuse and looks like alveolar filling pattern. So it is diffuse alveolar hemorrhage in a case of systemic lupus erythematosus. Bronchoscopy, we can suck out and the valve fluid will show the ferritin laden macrophages. That is diagnostic of intra-alveolar bleeding. This is another interesting case. A lady from Tripura, Agartala, she went to a hospital in the south with chest pain, left-sided upper chest pain. They have investigated the case. The X-ray showed there are bilateral honeycombing of the lower lung field, both lower zones. So they diagnosed the case as the interstitial lung disease. And what happens to the chest pain? They thought it is a cervical spondylitis, and they give some antibiotics, and they had the CT that shows honeycombing, typical honeycombing in the lower zones, and also, and they had bronchoscopy and valve fluid. At that time, the diagnosis of ILD is sufficient. The classification of the ILD was not there. So she came back. And as her brother was a pharmacist of North Bengal Medical College, he came to me because her main problem is the chest pain, and that is not resolving with painkillers. Now, same X-ray that is done earlier, a radiologist may miss it. But when we have the clue that there is a chest pain, severe, progressive, persistent chest pain, we cannot ignore it. And whenever there is a problem, you can pose the X-ray in this fashion. And then you can see clearly there is a reversion. And that case was diagnosed as non-small cell lung cancer. So it is the case of non-small cell lung cancer along with the DPLD. So it may be related to asbestos exposure. In case of asbestos-related lung disease, the bronchogenic carcinoma is much more common than the mesothelioma. Mesothelioma is not common, and the lung malignancy is much more common, particularly those who smoke. But we do not get the history of asbestos exposures in this lady. And what we get that she is living in a room with asbestos roof. And that is a remote possibility, but the diagnosis is bronchogenic carcinoma with ILD. The meticulous examination of the X-ray is also very important. You can see there are two opacities, round opacities with X-cell calcification. And this X-cell calcification occurs in silicosis. She is the wife of that case I have shown you. The family, the male has the advance, and the female, the lady has the silicosis with X-cell calcification. Now there is another X-ray. Look very carefully. It is again a rare X-ray. You can see pericardial calcification. And how the patient will present? Patient will present with ascites, usually. Patient will present with ascites, and in a case of ascites, if there is tachycardia, if JVP is raised, then we must be careful in the diagnosis of constrictive pericarditis. We should search for early third heart sound, and that is called pericardial knock. Nowadays, the echocardiography is very useful for diagnosis. But in case of ascites, if JVP is raised, please search for the constrictive pericarditis. There may be past history of pericardial effusion, tubercular pericardial effusion, or maybe traumatic. Usually it is due to tuberculosis. There is a right upper zone opacity. So patient was diagnosed as tuberculosis, sputum was negative, and there is an opacity here. Now, if you are careful, then you can see the opacity is continuing outside. So whenever there is abnormal opacity, you should stress it outwards. And so it is a chulate vein. And the X-ray done with removing that artifact, X-ray was normal, so it is not a tuberculosis, it is an artifact. Again, this patient present with dyspnea, and there is opacity. Somebody says it is pleural calcification or abnormal opacity, but if you can continue, it is continued outside the thorax. So it is a jorid part of the shari, and that looks like that. But with this artifact, you cannot miss there is a pneumothorax on the left side, for which she has come to us. Here, this patient present in the emergency room with severe dyspnea. You can say trachea shifted to the right. That is opacity, so it is fibrosis. Heterogeneous opacity, it is not looking like the collapse of homogeneous opacity. It is heterogeneous opacity with trachea shifting, volume loss. There is fibrosis of the right upper lobe. And you can also see the pericardial pleural calcification as well as the angle is obliterated. But whole the right lung events are chronic. They cannot cause sudden dyspnea that bring the patient to the emergency room. So there was a pneumothorax here. You cannot miss the pneumothorax. Because of the already compromised lung function, the small pneumothorax caused havoc in this patient. Again, this is patient.
Sorry to interrupt, Professor Sarkar.
Ah,
Actually, you have to wrap up the session within 2 to 5 minutes so that
5 minutes.
if any question arises, we can address them. Okay.
Okay. So I can skip this. I can also skip this. Now this will be the last. Now what CT shows? CT shows there is ground glass opacities. What is ground glass opacity? It is that when the opacity, through the opacity, the underlying lung marking are visible. So this is mainly the ground glass opacity. There are also cystic spaces as well as there is fibrotic spaces. So it is an NSIP pattern, fibrotic NSIP pattern in the CT. But why I am giving this case as my last case here? Because the esophagus are dilated. You can see the esophagus is dilated. Now, clinically, what happens to the patient? Patient has Raynaud's phenomena. Patient cannot open her mouth. And the eyes cannot be opened. Patient has dysphagia. The clinical echo and electrocardiological evidence of pulmonary hypertension, though there is no renal involvement. So it is systemic sclerosis, ILD, and the clue is in the esophagus. So thank you. I have finished it almost. So if any question, I can answer this.
Thank you, Professor Sarkar. You have nicely covered all the aspects of this session. Now, I cannot find any question in the chat box. Still, I have one actually
Yes.
question. Rather, I
Not
should
tough question, easy question for me.
I should want to seek your opinion regarding one particular query, that if the radiological finding is extensive but the clinical feature is less, what is your opinion about this disease or entity? Clinical
Sometimes
feature less, radiological features are extensive.
so it always happens. Like you may get some patients with deranged lung function, yet patient doesn't complain of dyspnea. Sometimes
But
this occurs. On the other hand, patient presented with dyspnea, lung function shows normal. Similarly, in chest X-ray, sometimes there is diffuse opacities in the lung. The chest X-ray is very modified, but yet patient do not have any symptoms. And this is found in early stage of alveolar microlithiasis and also in case of occupational lung disease, particularly ferritosis, iron exposure, in teen exposure patients, this may happen. The lung is totally covered with the opacities, yet patient do not have any symptoms.
Thank you, Professor Sarkar. Now, I think every attendee has actually enjoyed the session. Now, with this, I'd like to hand over the microphone to the organizer to conclude the
Okay.
session.
Thank you, both the speaker and the chairperson. It was a very nice. I think Dr. Dori was asking regarding this PSP, no, pneumonia, where your question
Yes,
was like,
to some extent, the pneumonia,
No,
definitely,
actually, in
pneumonia is
PSP,
one of the.
what is happened? There is disproportionate hypoxia. If the chest X-ray cannot explain the hypoxia is disproportionate to the chest findings. In those cases, PSP must be thought, particularly if history shows that the patient, the habits, behavior and behaviors may be there. Particularly. Okay, sir.
thank you. That
Yeah.
was a nice, very nice presentation, of course. And today's attendee was very high, about 60 at some point of time. Now I will request one of our course director, Professor S.B. Ganguly, to please conclude by giving vote of thanks.
Now, vote of thanks to both Professor Supriya Sarkar and Professor Devari. Really, it is a very, very educative session. Now, after retirement from the government hospital, now I am in different corporate hospital, and their trend is to direct city without performing the chest X-ray. It is a very dangerous situation. But if auscultation and chest X-ray are done properly in respiratory medicine, very little is left. I congratulate Supriya, and many cases he has described, especially two: differentiation of non-cardiogenic edema and ARDS by chest X-ray is possible, and even mitral is possible by chest X-ray. If you guys wanted,
Right.
and on chest X-ray, by filling of the pulmonary diagnosis, mitral sensor. Thank you, Supriya. Thank you, Professor Devari, for your tremendous and very educated class. Thank you.
Thank you, sir, for giving me opportunity to have a class in this prestigious class. Thank you, chairperson, also.
Okay.
Thank you.
So you conclude, and we'll let you know regarding our next class. In September, we think we have our this Eastern Journal Conference. We have to adjust our classes.
Okay.
Okay.
We will let all the students know our next class in WhatsApp.
Yeah. Thank you.